Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Welcome to Back in Action. Josh here with Coach Dusty Holden and Dr. John Lavelle. Welcome, gentlemen. Thank you for being here. Today, we're going to kick it off with Spine 101. What do I need to know about my back? And I wanted to start with you, doctor, if you would. Run me through simple spine. Like what are we looking at? T-spine, C-spine. What are the things and the stuff that are the most necessary for a human that has a spine?
For sure. This is my wheelhouse. That's what I do, spine medicine. So this will be a good day. We can lump it all together. So you got the cervical spine connecting the head.
Okay.
Comes down to the shoulders where you get into the thoracic spine, which we call C-spine is cervical, T-spine is middle of the back, and then that goes in when you get to the low back, the lumbar spine. And then that connects you to the pelvis and the sacrum. Sacrum is kind of its own bone now, but it used to be 4 different vertebrae there which fuse into a sacrum, so that makes up the pelvis where you get pelvic and sacral rotation.
When you say movement. Used to be,
good question. In utero. So, and in our early age, so those vertebrae fuse together to form a bone, the sacrum. And then below that, you have a coccyx, which also used to be individual bones. All that kind of fuses together to be like what we call the tailbone, things like that. But the individual vertebrae, lumbar, thoracic, cervical, where you get motion there. So that's kind of the rundown of the spine. But that's just obviously the basics. So within that, we'll kind of lump it all together. If we go from inside out, why do we have that spine? That's just a group of vertebrae. You can think of it like a circle that's making a bony structure to protect the most important part of in our body that connects to the brain, our spinal cord, and the spinal nerves that can come out. And that's what gives us sensation, motor function, so we can move our limbs, our body, everything goes through that channel. So that's why we have those vertebrae throughout the spine that connect up to the base of the head to protect the outgoing brain, which is that spinal cord coming down to control our body. So we get all our nerves through that area. So you have the bony structure, and then in between each one of those bones are these little discs. So the discs are, people call them like shock absorbers, cushions. You used to hear a lot of people call them like a jelly donut. It's nothing like that. They're a pretty solid structure. They have this hard outer ring called the annulus fibrosus, and that's about 20-25 rings that encompass this inner nucleus pulposus. And that nucleus isn't a gel that squirts out, so you hear people talk about disc herniations. It's not actually a gel structure. You know, some people will say it's more like a Brillo pad. It's got proteins that interlink in there, and it's about 80% water molecules in there. So it is not a fluid, but there is water in there. So that interlocking makes it a pretty solid structure in there, but it's softer than the outer rings.
Okay.
And so that's in between each one of those vertebrae, and that helps those vertebrae have some more movement. So that's kind of in the vertebral bodies. Under those, each vertebral body, if I had a spine, if I was smart enough to bring one, we could see that. So you have the vertebrae linked up, then you have the spinal cord, and then the back part of the vertebrae is joints that connect the vertebrae to each other, called the facet joints.
Okay.
So the disc can have some degeneration. Those facet joints get degeneration with time, and you develop arthritis there. And then you go from inside out. Then you have ligaments that connect everything. So you have ligaments that connect the vertebrae, the anterior, posterior ligaments, the ligamentum flavum, interspinous ligaments, supraspinous ligaments, intertransverse process ligaments. So all those ligaments are then on the outside. And I mention all these things because these are the things you got to think about when people develop pain. All these things can go haywire or have strains in them, tears, rips, arthritic change.
That's a lot to think about.
It is. So then when you get outside the ligaments, you have the muscle tissue. So you have what I just generally refer to as posterior chain muscles, or the erector spinae, which is made up of 3 muscles. Iliocostalis, longissimus, and spinalis are kind of the bigger ones on the outside, but inside that there's a very important one, especially in the low back, called the multifidus muscle. Yeah. All those you can get strains in. Then encompassing those muscles is, sometimes people think of it like saran wrap, kind of covering those muscles, the fascia. And that fascia has nerve endings, so that can be a big cause of back pain, just straining that fascial tissue. And then outside of that, you get the subcutaneous, the skin, and stuff like that. But within the spine itself, you got to think of the parts of the anatomy that we mentioned, the bones, the discs, the joints, then the ligaments, the muscles, and the fascia, that can all have issues go wrong when you're trying to talk to someone. A lot of this, people will give you that information. But so a lot going on there. Again, all that is there to help us move, but protect those spinal nerves that are coming out of the spine.
That is a lot going on.
That's a lot.
That's a lot going on.
Which makes it so complicated.
Yeah.
Now, so talk me through the way that what is the, and we can contrast this from the athletic standpoint and then the doctor standpoint. What is the spine's favorite way to move? Because we know it moves through flex and extension. We know it likes to rotate. We know there's a torsion. Mm-hmm. What's the favorite of the spine?
Like which it prefers movement? Mm-hmm. Probably flexion.
Okay, flexion. Now, if flexion is the spine's favorite movement, which movement is going to be most commonly associated with injury?
I would say it kind of depends. So whether you're talking about the neck, cervical, or the neck, cervical, thoracic.
Can you give me all three?
Yeah, sure.
Yeah.
So in the neck, I would say you're going to get more injury with extension. And
okay, so that's pushing my chin towards the sky.
Whiplash.
Exactly.
Okay, whiplash.
Yeah.
Okay, is that the most common that you get out of the neck? Is it whiplash?
Well, it's not. I wouldn't say the most common because now it depends. So with traumatic, it's often that extension of the neck. But from everyday use, it's more of the forward flexion.
Yeah. Is that an actual bone issue that we're talking about, or is that more of a muscular?
More muscular.
Issue? Okay,
yeah.
gotcha. And
throughout the spine, the most common is myofascial, so muscle and the fascial tissue getting
Is
strained.
that because so is it the muscle becomes inhibited and no longer works because it's not strong, or is that because we're straining it?
Both. I think they go hand in hand.
Okay.
More people are going to strain their muscle. Muscles get quote unquote tight, or you get hypertonicity in the muscle from that strain or from that deconditioning. So if you're constantly like this, we'll focus on the neck right now, but those neck muscles are always under tension. If you're always looking down at the phone, on a desk, just day-to-day life now, so electronic, we're often looking down. Over time, as we get older, those muscles are constantly in that forward flex position in the neck, under tension. And if those muscles are also getting deconditioned, they have to work harder to hold it in this position, and that's where you get that strain. So you wake up one morning, the neck feels tight. Didn't happen because you woke up that morning. Obviously, you've done that a million times.
It's been compounding over time.
But it's building up in the background. And then finally, it just sets off. Those nerves start to get sensitized and react to it.
Now, when you say flexion is the most common, then I want to toss that over to you. Does that mean we need to train flexion a lot?
I think yes, we need to be strong in that movement because it's so common.
Okay.
But
then what's a neutral spine? So why do we hear neutral spine a lot if we need to be training in flexion? Because I'm sure most of our listeners have heard, I want you to get a flat back. But you can tell me the difference between maybe a neutral and a flat back or so on and so forth. But if flexion is the most available or the movement pattern, which is hunching, that the spine likes the most, then does that also mean that we need to train that movement? Or do we need to train another version of that movement?
Yeah, I think that's a big one because we get maybe it can be even overtrained or overused. So then just the introduction of extension.
Yeah.
A lot of times, McKenzie method is a very common, method in relieving back pain, and it's an extension.
So if we're thinking of, if we can say that for our listeners, the McKenzie method, I would be usually I'm all the way down on the floor, lying on my chest, and I'm pressing either off of my hands or off of my forearms into what would look like an extended position.
So with McKenzie method, it can be flexion or extension. It's kind of a good therapist will use it as an evaluation tool for freedom of movement. Are you easier in flexion or extension?
So you assess which range of motion is more threatening to the athlete.
And then you treat with that freedom. You put them in the position of ease, basically.
Gotcha.
So it can be used to treat flexion or extension. However, because what we're talking about, a lot of people are flex forward or a lot of flexion can put pressure on those discs. A lot of times we think of McKenzie as all extension-based, but it's extension-based McKenzie treatment. So McKenzie is the evaluation, and then you treat off that either in flexion or extension. But often it's used as an extension.
So just so our listeners know, if I wanted to do that into a McKenzie extension-based exercise, I might lie on the ground and try to do, explaining it like a push-up without actually lifting my hips. Like I just leave my push-ups behind and just raise my upper body.
Yeah.
And what am I looking for? Am I looking for pain to go away? Am I looking for?
I think it could, yeah.
Okay.
I mean, definitely in some cases it relieves pain.
Or am I looking for pain? If that hurts, then I know I'm extension intolerant, and I need to train more into flexion until that goes away.
Yeah.
Okay.
Well, you said what's a neutral spine, and I think a neutral spine, that's a good one for people to try to work toward because it requires a lot of muscle engagement, activation, like making sure that they can fire the glute,
Okay.
activate their core.
Yeah.
So a lot of people don't even know where that position's at because it takes being intentional.
Yeah.
You can get into extension or flexion and maybe not necessarily be trying to do it. It could be passive, depending on where your weakness maybe lies. And I mean, again, this one is a very common position that most people find themselves in now. Well, if you work from this position for 8 hours a day,
and it's
probably not very active.
You're showing a question mark position of the back where I'm rounded over.
Yep.
Now, what we're talking about, let's say that is flexion, and there's an end range to my personal flexion of that question mark position. Now, the opposite of that is the end range to my extension.
Yep.
Would neutral be somewhere between that? Question number one. Would neutral for me be neutral for you? Question number two.
No, I think that could look different.
Okay.
Depending on there's a lot of factors there.
Male, female,
age. Because again, if it's been a situation where somebody's been in this flexion position for 30 years, their extension may be very minimal compared to somebody else who has really got that range of motion in their thoracic spine. So
this is I wanted to bring that up because I'm glad that you said that. I think that this is what a lot of us see when we go to a gym where there might be 20 or 30 other people. We'll look down the line and think something like, oh, I need to look like them, when that may be the worst thing for you. Mm-hmm. You need to do what you can do best, not necessarily what the guy beside you is doing or the girl beside you, because they may have a completely different range of motion.
Yeah. Well, what does everyone like to do at the gym? Most people
look in a mirror. Compare.
Yeah.
I mean,
look in a mirror and they want to look at their chest and their thighs,
Okay. Yep.
So that's all in the front. That's bringing you forward. A doctor I used to train that trained me in med school, Dr. Heinking, he would always say you got Cadillacs in the front and I don't know, we'll call it a Prius in the back. So they're all big up here, bringing like this. So everyone's training the front too. And what's the hardest day? Back and legs. No one enjoys that as much in the gym, the everyday person. So that helps you get neutral spine if you're training at all.
So I talk about this a lot, Dusty. Tell me if it sounds wrong to your ears for training athletes. But there's the go muscles on the front. There's the show muscles on the front. There's the go muscles on the back. Generally speaking, again, taking into account whatever sport that you play, we train the posterior muscles or your go muscles 2 to 1.
Yes.
Would you say that that's okay?
Yeah.
That's a good philosophy to live by. Yeah. So for every time I push, roughly, I would pull twice as much.
Yeah.
Okay.
I've never heard that.
That tends to get athletes in a good realm. Now, there are, of course, sports where you may not be able to do that, but that's what sport is. Sport is flirting with something that might not be the best human behavior for something that works out really well on the field.
For what it is that you're doing.
Yes, exactly right.
Yeah.
Now, you mentioned a lot of stuff, but I really wanted to get into, and this is obviously we're talking about injury. Walk me through some of the injury that you see the most when it comes to the spine. Maybe this is the one I see the most or second most or so on and so forth. And then we'll talk about how we treat, if individually or all together.
Yeah, I think when I see someone comes in, I'll get to that question in a second. I'm thinking, is it more axial back pain? So is it right along the spine that it hurts? Or are they getting radiating pain? Is it irritating those nerves coming out of the spine to go down the arms or legs? So that's my initial kind of eval when I'm even walking in the room, is trying to find out, are they having referred pain, radicular pain from a radicular nerve, which are the nerves that come out of the spinal canal that spinal column is protecting, those vertebrae are protecting. Is there a nerve being quote unquote pinched or irritated to give pain? Or
that sounds like answering the question in a part, like is that the most common?
No, the most common is just axial pain.
Gotcha.
So just straight along the back.
Will not have a nerve pain.
It is nerve related, but it's not a nerve, one of the larger radicular nerves shooting down the legs.
Got it.
It's just along the spine.
So if I have axial pain, I'm not going to feel my foot.
Exactly.
Okay, got it. Sorry to interrupt.
No. And so then what's causing that axial pain? If we stick with that for a moment, is it deep within the spine? Is it a tear in those outer rings of the disc, that annulus? And those discs all tear as we get older. In our 20s, 30s, 40s, there's no one that doesn't have a tear in the disc. It's like gray hairs and wrinkles, as I say a million times. It's just part of that aging process. Now, genetically, some people get it sooner than others. Genetically, some people their nervous system and enzymes, they're inherited. You're going to feel that more than others. But is it a tear in the disc that's causing pain along the sinovertebral nerve in there that monitors the outside of that disc that's getting irritated? Or is it more arthritic change? Is it those facet joints we talked about where you have arthritis? Again, everyone gets arthritis, but has it become flared up from an accident, trauma, overuse, sitting too long? Or is it just that muscle, ligaments, or fascia that's been strained? Again, we see that a ton. I would say that's one of probably the most common injuries. It's just a strain in the ligaments or muscles or fascia. I mean, you could do a quick Google search or search on AI with Grok, and that's going to be the thing they say the most. It's most commonly a muscle strain. 2 to 6 weeks, it'll get better, and then you move on.
And this is what we talked about previous episodes, that 90% of all back issues heal on their own.
Correct.
Okay.
And it's not just because even if it's a disc or joints or a pinched nerve, they're going to heal on their own too.
Okay.
There's ways to kind of hasten that healing, and we can help it along. But typically it's an overuse or from being too sedentary or playing where you're just sitting too much, meaning overuse just being too sedentary, or overuse where you're an athlete and you're playing baseball 12 months of the year, swinging, pitching, and you strain those muscles because you're not training them.
Okay. Yep.
So I would say that's the most common.
And then where do we go from there? How does that relate to, well, I mean, you can tell me the difference between a herniation, a bulge, so on and so forth.
Yeah, so if it's not just muscular, but often there's always going to be a muscular component because if you have arthritic change or a disc problem, the muscles are going to tighten around it to protect that area. So all this is working to protect the spine underneath, which is our nervous system that controls our body. But let's start with inside out again. If it's that disc that we talked about, over time you're going to get a tear in those lining of the disc. And sometimes, whether it's traumatic or just from slow progression with time, some of that inner nucleus material can push through those rings and come out, which we call a disc herniation. Now, that can be based on the way that disc herniation looks. You could call it a disc bulge, a disc protrusion, a disc extrusion. So there's different terminology for that, but all under that same umbrella of degeneration, that disc, and that disc starts to push outwards.
Okay.
Now, it's not movable. Once that disc protrudes out, a lot of people say, well, we can treat it and get it to push back in, or they call it a slip disc. It's not moving like that. Once it's protruded out, it's a one-way street. It's there. If it's big enough, sometimes the body will see that as foreign material and clean it up. Well, that's what a spine surgeon would do if they had to do surgery, go in and clean out that disc protrusion, but it's not going back in. But as we've talked about in prior episodes, you don't most of the time, I would say less than 1 or 2% of the time, do you have to go in and do anything surgically with a disc protrusion, because the nervous system is just going to recognize that as the new normal over time.
What am I feeling then when it hurts, and then what am I feeling when it doesn't hurt?
So when it doesn't hurt, you won't even know it's there.
I guess my question would be, how does it go? How did that improve if it doesn't change
so typically, when you get a disc protrusion, it's because it's hitting one of those larger nerves that come out for the spinal cord, and we'll use the low back, and goes down the leg to the foot.
Okay.
So one of those lumbar vertebrae is getting either pushed up against from the disc, but even that's usually not the most common. Usually it's just irritating that nerve.
Okay.
So it might be positional. Every time I bend and twist, I'm narrowing that space where that nerve is traveling through, where that disc is bulging, and getting irritated. To give you, it could be numbness, it could be weakness, it could be pain down that leg that you're feeling. So often, majority of the time, we can work together through training, sometimes medication like a steroid if there's an inflammatory component, or an injection to quiet that nerve down. But usually sometimes it takes a while, but a couple months, 5 months I think is on average, that nerve will start to adapt and desensitize. Okay. So it'll just recognize that disc being protruded as the new neutral spine or normal spine. That's just the new place that nerve's going to live.
And I feel that immediately as the worst thing, or I feel it.
Usually atraumatic. You just start to develop it. Because you woke up one morning and that was the time it was going to set off.
Okay. And then from there, though, you're saying roughly could be up to 5 months. It'll adapt to it, but it's not changing shape.
No,
it's not going back in.
So, and that's for somebody who's just resting.
What do you mean? Like 5 months?
Yeah.
Well, they're probably resting, or they're just trying to do day-to-day activities, but avoiding things that they've been told will exacerbate, like forward flexion or bending, things like that. But yes, if we get them started, this to your point that you're getting at.
Yeah.
If we get them moving more,
Yeah.
they're gonna that nerve will desensitize much quicker.
Well, okay, so when you say much quicker, like what would you say
Like
the
if I could
average
see-
would be?
A couple weeks.
Oh,
So you're
that's a
talking
big difference.
A couple weeks versus 5 months,
Yeah.
6 months.
Yeah.
Yeah.
Now, in that couple weeks, let's say they're working with you or physical therapy. Maybe I do an injection to help quiet that nerve down, just so they don't feel it, so they can move easier without trying to work through. Sometimes this is 10 out of 10 pain. A lot of people, women, will say it's worse than childbirth when that nerve's being pinched, especially in the neck, because you got to use your neck all the time, and it's going. That one of those cervical nerves goes down the arm and into the hand, and it's constant numbness, pain. I mean, that's pretty miserable. They'll always come in kind of looking like this or trying to get comfort, but you can't. So whether it's an oral steroid, but often a steroid injection, just to help quiet that nerve down. And it's not always inflammation. We use steroid and numbing medication in the injections, but some people can't tolerate steroids. So even just putting lidocaine around that nerve helps desensitize. Basically, I always call it like turning on and off a circuit breaker. You're shutting down those sodium channels with the lidocaine along that nerve, so it can't send that pain signal. But then it almost resets it, and then that nerve, because that lidocaine's not in there very long.
But this is the most opportune time to go train, correct?
100%. That's the only reason, in my opinion, to use injections if they're going to go do something.
Okay.
The injection's not the cure.
So would it be safe to say then that the injection is the passive treatment meant to be followed by the active treatment,
100%.
which is the workout? Okay, so now we have that. If I went to you today because I was feeling whatever, and then you were like, yeah, that's definitely a disc bulge.
Yeah.
At what point in time should I go to Dusty? And then I got a couple questions after that.
Day one.
Okay, so if I went to Dusty on day one, you just sent me there. Where am I at in terms of I have a disc bulge? What are you going to do? Assess? What are you going to assess? Where am I going to go from there?
Well,
what can I expect?
We're kind of going to go back to really just evaluating certain movement patterns. One being the flexion, the hinging, because it's just the most common. So, do you have pain? Where do you have pain? At what point do you feel it?
Okay.
But we're also going to look at extension. So really, it's just assessing, like, how are you moving? Do you have pain? In a lot of assessments, I mean, somebody's got a disc bulge, herniation, and we run the assessment, and there's no pain.
That's right.
So, that is more to just kind of see what can they tolerate, what can they not tolerate, and to know. Because the plan is we want to get them moving as quickly as possible, like day one.
Yeah. Why is movement and medicine in that? What is it that makes things feel so much better?
Well, I think just psychologically, because your natural tendency when you are in pain is to stop. So that just in itself can be life altering. You've changed everything that you're doing on a daily basis. It could be work, it could be just family, but that doesn't take long. A couple of days of your life being very abnormal from a movement standpoint, and it has a massive impact on somebody psychologically. So
when you say that, it's really interesting though, because before you even got to that, I was thinking, tell me the difference of, so it happens to me, I've worked out every day for forever, great. I'm gonna obviously try to keep working out.
Yeah.
Right? I've done it until that thing, and now I'm going to keep trying to do it. Okay, but what happens if I'm the person who hasn't done anything for 10 years? Dr. Lavelle just sent that in. What's that like?
Well,
do I walk in like on pillows? Is there a huge difference?
First of all, half of them aren't going to walk in.
Yeah.
Okay.
A lot of people won't come to see us. But even you really, for us, we're very sensitive to that person.
Oh, for sure.
Knowing that gym in general is somewhere that's very intimidating.
Yes.
That if you weren't coming here before you had this issue, the likelihood of you coming after, it's very minimal. So the fact that you walk through our doors, we don't take that part lightly, So it's all about building rapport and confidence with the person, letting them know, that, hey, we understand what you're dealing with. We understand if you're hesitant, to even try it. So it's just being delicate in how we walk them along the journey, letting them know we're not in a rush. We don't have to, speed through step 1, 2, 3. We can spend a lot of time on step 1 if that's what we need to do for that person. And so,
you said a good point there, though. It's for that person. So when I go in, you're going to probably have a completely different idea of what you would do with me if I was experiencing the same issue as somebody who might have just gotten off of the couch.
Because you already know the value of it. Okay. You were doing it before. You know the value. Maybe something's happened, but you already understand the process.
Yeah.
So for somebody new coming in, they don't know the process. They don't know the value. They don't even understand the difference between soreness and pain. So it's even
tons of education.
We've got to walk even through that journey of, okay, now after we've trained, like how are you feeling? Is it pain or is it soreness? And really helping them understand those two are very different. And one is good. That means we actually worked some of those areas that we were trying to. I think it's just being patient, taking time with people, because everything's so systematic, there's always it's like step 1, 2, 3.
It's all those algorithms which slow the process down, but also makes it impersonal.
Yeah.
So when someone walks in your door and you're starting to instill that confidence in them, where they can move, even if it's just a little bit day 1, when they haven't been off the couch or done much, they're retired, they're just trying to enjoy their golden years.
Yeah.
When they're trying to get moving and they're scared, they're afraid, having that individualized approach, but you kind of reassuring them, but one-on-one instilling that, that they trust you and building that rapport, I think is half the battle.
What's really interesting,
I agree,
Dr. Lavelle, is that you have, for better or worse, an appeal to authority. When you say something, people are really going to listen.
Well,
maybe
not in my house with my kids.
Well, I think Dusty and I listen to you. But what I was going to say is, I don't think a strength and conditioning coach, movement expert like yourself, has the same appeal to authority, and that's a society or a culture-based thing.
Yeah.
For better or for worse. So, how do you work within that again to calm that cultural difference that walks in? Doctor says X, I'll do it.
Yeah.
Strength and conditioning says X, I'm going to question it.
Yeah.
How do you overcome that?
I think just taking the time to talk people through the process and that we're doing. I let them ask questions.
So that goes back to the education. The only thing we're really asking is an initial trust to come in.
Yeah. And I think that's where Dr. Lavelle does a good job. You don't take lightly in who that you refer patients to. I think that's another reason why people respect what you say, is because you have a track record, and I think that's...
Well, patients love when I say, you're going to go see this therapist or you're going to go see this trainer, and I give them the name. They're like, whoa, this is going to help. It makes it so much more personal than when you just follow the algorithm. Like, here's a script for PT, it just says eval and treat. And
or you go pick your own. It's like you have specific people that you have, again, like worked with in the past, you've seen results. And so I think that part's important, because, again, people, they're putting trust in him just to come walk in to see me. Yeah. So I don't take that part lightly either, that he has the confidence in me to send his patient, because that's his reputation that he's putting on the line. But again, I think it's just it's taking the time to hear people. What's the journey been to get to this point? And honestly, I say this like jokingly a lot, but we pretty much find ourselves as like the last option. We're not the first option for sure. In most, I would say 9 out of 10 cases, people have literally tried everything before they've walked through the door to even give me and you a shot.
Here's this morning, just a patient today. She hasn't done anything, but she's so bad wanted to get treatment. She's one of those that has been sitting around, doesn't work right now. She was on her way to her appointment. That's why I was late to the podcast today. Her car broke down. She went to the rental place to rent a car just to get the injection. And I was saying in my head, would she have done this to go to therapy? to go to training, not a chance. She would have skipped that day.
Yeah.
So people want that quick, easy fix. That's why it's the last resort.
Yeah.
They want even sometimes surgery, though that's thankfully culturally changing some. That's not always the first jump. But they want that quick fix, that easy solution. And so when they come to me or you guys and you start building that rapport and trust, people love that. They love that community feel.
And unfortunately, it's very novel.
Yeah,
it's very novel.
It's that one-on-one
so
relationship is unique, but that's what makes the difference.
I want to go the other way. Okay, so we didn't start with the good doctor having a problem. We started in the gym. I'm somebody who's doing all the things and the stuff, and then something hurts. When do you refer out? What are the red flags, and what do I need to look out for? So me, again, if we're just using me as an example, doing this for decades, I'm going to push. Yep. When do I need to stop?
Where I'm going to refer out is when you stop coming or you stop moving.
Okay.
When I see that person who's been doing the thing for a decade, and now all of a sudden they've been trying to, train through it, but it's not helping. They're not seeing improvement. And then I see them to not be coming to the gym, and I see a change in their behavior and demeanor. That's when it's time for intervention, like, hey, now this is where you need to go get this checked out. And in a lot of cases, it's just so he can reaffirm.
Back to the appeal for authority, so he gets somebody else that's saying, hey, this is still a good idea, just maybe modify the way that you do the things.
And maybe there's some acute disc herniation. Sometimes you can get a compression fracture in the disc. Maybe it is something that is going to slow you down for a little bit, but not stop you. But getting that evaluated when he sends it in, I usually know those are hard people to treat. When they've been training for 10 years, it's not as easy as someone that hasn't been, because they're already doing it right. They have strong back muscles. They haven't got that muscle atrophy that puts that spine in a, unstable position or non-neutral position.
Yeah. It would be unfair to ask you, what the percentage is, because obviously it's going to go on to one side. But all things considering the same, if we didn't have more of a sedentary population, do you think that those numbers would line up more with people going to see you that were coming from a gym, or would they still be so few and far between versus the people who hadn't been doing much?
Oh, it would be, I'd see a lot less patients if people were active and in the gym.
Okay.
100%. Because a lot of it, as I said, probably 80% is myofascial muscle strain, muscle ligament issue from deconditioning.
Yeah.
You see, one of the newer things people talk about now, and I've tried to encourage radiologists to read this, is those posterior chain muscles, those posterior muscles in the back. When we look at them, what is their circumference area? Have they had that muscle atrophy? Has there been fatty infiltrate because they've lost the muscle mass there? And that's almost universally with sedentary people.
So let's say that again. That's really important. You want somebody to look at an image of the musculature that's always on
posterior
in
to
the back.
And it's almost never read on an MRI, but
and
almost
I'm
all the
looking
time
for
with
it
patients
to be
I
atrophied.
see with back pain, they have loss of that muscle mass.
Oh, wow.
So those erector spinae muscles, the multifidus, which is the smaller muscle that attaches right to the spine, that does some of that quick initial 15 degrees of rotation or flexion when you're moving that spine. That's the initial muscle that
and part of the pelvic floor
contracts.
Also, right? The multifidus is part of the pelvic floor.
Well, it's posterior.
Yeah.
So it's not in the pelvic floor per se, but it does attach to the pelvis.
Okay. Now, if you're looking at that to be atrophied, can you then make the next qualified statement that says, if that is atrophied, I will have back pain? Can you come close to that, or is that getting a little too much?
I could say you're gonna be predisposed to back pain for sure. I've never thought of it that way, but I think you could almost say that. Because everyone I see, I would say everyone I see, unless it's an acute injury like someone in the gym that's been working out and has an acute disc issue, but if it's not that person, on the day-to-day average person, they have muscle atrophy back there in those smaller muscles.
Also glutes, or specifically
the back
muscle?
MRIs I'm usually looking at go from the top of the sacrum pelvis in the lumbar spine. Because because those algorithms, insurance wouldn't pay for the pelvis to be done too.
Dusty, you would have more purchase over that. Do you see people that have a harder time recruiting the glutes have more issues or not? Or is that just a thing that we hear a lot of in the fitness world?
Yeah, I would say almost every patient for sure that comes in if you're having back pain due to a sedentary lifestyle, it's almost universal that you do not know how to even activate your glute. You know,
yeah.
I mean, one of the common movements that we have in the assessment is a glute bridge, and most people are like they feel it in their hamstrings.
That's right.
Well, you can almost guarantee if someone comes in with a flat butt, no ass, they're going to have hip pain or low back pain because they got nothing stabilizing that.
Yeah.
So eventually something's going to get strained or they're going to get some instability in the spine.
Well, that goes with what we were talking about, show muscles and then go muscles. So if the interior is constantly doing a lot of work to make up for the posterior, then there's already an asymmetry.
Right.
There's already something building underneath of the surface, probably where the quads start to take over for the abs, and then you just have a whole bunch of issues going on.
Yeah.
Now, I wanted to get to, so now we've talked about that. What if I don't have anything going on? What are some tips so that I don't have anything going on? Now, you said it a few times, and you said it in numerous podcasts. Is it just going to be age, and I'm just going to have to deal with this? Like,
No.
Is it going to come up at some point in time?
Well, the degeneration, everyone's going to have it.
Okay, but it doesn't mean pain.
It does not. Because we all have some degeneration in our spine. If we all go get an MRI right now, I'm going to show you something in your discs, in your joints that are degenerated with time.
So why don't I feel
guys.
it, and why does somebody else feel it?
Because of what's their lifestyle, typically.
Okay, so what are some
doing.
lifestyle tips that I need to do right now if I'm not doing anything?
Everyone should be active with some exercise, including strength. Strength is the key because everyone can go run or get on an elliptical or a bike because that's the easier thing to do. It's harder to go lift weights and lift something heavy. I'm not saying you have to be a bodybuilder, but you got to strength train those muscles. I always compare my patients, even if a 70-year-old man or woman that's retired, treat yourself like an athlete. Why are athletes, the best athletes, able to play LeBron James till at 41? He doesn't have a beer gut and no muscles. He stayed in shape. Tom Brady, why did he play till he was 40? Because he was working out, keeping good mobility and strength.
Dusty, as soon as he says aerobics, that makes me, the strength, because we're strength and conditioning coaches, obviously. Would you say that it would be better to be the person that didn't do anything or the person that I only run marathons? Because I feel like we see a lot of, hey man, I'll go outside and I'll run, but I will not strength train. So if I'm that kind of person, am I more susceptible or is it just kind of a wash?
So which one's better? The marathon?
If there was a better, which one's better?
I would say the one moving.
Yeah, okay. So movement, no matter what, even if it's
to the extreme.
Even if it's an aerobic movement only, the one moving is still going to take out. So that says a lot.
And they're going to recover quicker.
Okay.
Because you're just going to educate them that just do some cross training, add in some strength, and you're going to be able to keep running or keep riding bikes. Because that marathon runner, like anything we discussed with overuse, is going to get some injury, whether it's knees, hips, or back. But if you add in that strength piece, their body's used to being active and moving. They're going to recover quickly, and then you add some of that strength, and they're going to be able to get back to doing what they love.
So the World Health Organization recommends 2 days a week of strength and resistance for 30 to 45 minutes a session. Do you find that that's enough, or do I need more? More how much?
3 to 4.
3 to 4 days. How long does each session need to be on average?
I mean, anywhere from 30 minutes to an hour.
On average, what does my split look like? And by split, I mean, do we divide it by strength power? Do we divide it by upper lower? Is there a preferred method that you like, that you see more successful than another?
Well, I try to break it down into some type of squat variation.
Okay.
So some type of unilateral, like leg movement. So it could be like a lunge.
Okay. So if I box squatted and then I lunged.
Then a hinge.
Okay. Got it. So a deadlift or a single leg Romanian deadlift.
A push, a pull.
Okay. Got it.
A press, like something that's pressing in an overhead.
Landmine press if I'm missing shoulder flexion.
Barbell,
overhead
dumbbell.
press if I'm not.
Yep.
Okay. Got it.
Carry.
Okay.
Just carry heavy objects.
Okay. Single arm, both arms?
Both in different positions. Front backs, overhead, suitcase.
Got it. Okay.
So that's really that I kind of look at those things, and those are all the movements that I try to incorporate each week.
Okay, so let's not talk about the gym. We got the gym down. I'm going to go to you 4 days a week. What are some things that I need to be doing outside of the gym that can, again, keep me from having the issues? What are just a few tips that our listeners can do, 1 or 2 things outside of the gym?
Well, one is just walk.
Okay. So is that set a clock? Every 20 minutes I need to get up and do an exercise snack for 30 seconds or whatever?
I think if you're in a seated position for hours, then yes, I think every 20, 30 minutes, get up, move around, do some air squats, maybe some push-ups, just move around.
Okay.
It could be just walk.
Okay. What else?
Then I would just say that the biggest mistake that people make is avoidance. Is when you avoid things because, for example, with back pain, the number one thing that I hear is, I hurt my back, I don't do deadlifts anymore. Well, what's the best thing for your back? A deadlift.
Deadlift, yeah.
So, people make all these associations and link, certain things to, that's why I had pain, or maybe that's when I injured it. I think the moment that you start avoiding certain movements, that's when it gets tricky.
To be clear, though, and I've worked with you for a long time, if I walked in and I was the human that is scared of deadlifts, you would not have me deadlift right out of the gate.
Not initially.
You would build the rapport, but
my main goal.
You're going to get me to where I'm, again, let's not call it a deadlift. We're just picking something up off of the ground.
Yeah.
And that's what you do every day.
414 times, right?
You're immediately going to create a hot spot for me.
4,000 times a day.
No.
People hinge at the waist.
Yeah,
he said 445 or something a couple podcasts.
But
it's up to
4,400.
It's up to 4,000 a day. You hinge at the waist.
Is this a Google thing?
No, it's Grok. You can't go wrong.
Okay, got
it. It might have been Google. I have no idea. But it was 3,000 to 4,000. Think of how many times you're hinging a day.
Right. Yeah. Right. Well, and if that's a movement that you're avoiding in the gym, but yet you're going.
Oh, you're super fragile. Yeah.
You're just deconditioning yourself because you're not training it.
And it doesn't mean you have to
your injury rate just skyrocketed.
Yep.
We're not talking about max deadlifting. We're talking about picking up a light weight off the
Something
floor.
I can handle for sure.
Yeah, just to train. Well, like I just said, we're training you like an athlete. If you want to bend over and pick up a purse, or you want to throw that football 50 yards down the line, you got to train that shoulder to throw the football. You got to train those muscles in the back.
That's a good way to put it.
To keep it, as we opened up with, in a neutral spine position to bend and lift that.
So give me one tip to go out on that's different than what Dusty have to keep my spine robust and healthy so that I don't have these issues. What is one thing that you would recommend, or that you would like to see maybe all of your patients to do, again, besides movement, besides working out?
Oh, that's a good question.
Is there anything
So
else?
besides movement and working out, I mean, number one is strength.
Okay.
Number 2 and 3 is nutrition and sleep.
So nutrition being I need to be appropriately hydrated and I need to not eat a specific food, or what do you mean by nutrition?
So you need to eat protein and avoid processed foods.
Okay. Protein and avoid processed foods.
If you can raise it or grow it, that's what should go in your body. If it's on the inside of the grocery store, made at a factory with all these preservatives, food coloring in that's going to increase inflammation, that's going to be another podcast, but it's going to make those nerve endings sensitive and you're going to have more pain.
And then if you're not sleeping on top of that.
Yeah, and if you sleep 2 hours a day and then you sit at a desk all day, you're going to be in my office.
All right, gentlemen, thank you for your time. Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.